Good morning and welcome from all around the world for our 39 consecutive structural heart life cases, broadcasting directly from the cardiac catheterization laboratory at Mount Sinai Hospital in New York. I am Pedro Moreno. I'm professor of medicine, interventional cardiologist, and I will be your moderator today. We'd love to hear from you. So please send us all your questions on the website. Before we start, I want to thank you for participating in the virtual New York transcatheter valve course that was held Thursday, December the 10th. To view those live cases, all of them are recorded, and you can just go and visit our www.nytranscathetervalve.org. We have a very good case today. And let me take you to the cardiac cath lab on Mount Sinai Hospital for the direct transmission, Dr. Sharma.
Okay, good morning to our structural live webcast viewers. Welcome of the new year 2021. Has to be that 2020 never happened. So we are post-COVID, everybody getting vaccinated globally. In various parts. I know that in India they're starting vaccine next week. In America already started last month. Should be a bright and new 2021. With that case, we said we give a remarkable case. The case which we are going to present today probably will be the oldest patient of the tower. We looked into the literature. It was 102 plus change years a patient reported, and this Centenarian patient is 104 11 months and 28 days. In 3 days, patient will be 105 years. We actually have done the valvuloplasty on 104 year. We published in AJC about 15 years ago, balloon aortic valvuloplasty. But with that note, let's go through this case, which has lots of challenges, which happens. Imagine if you become more than 100 years of old, what will happen in your lifetime? And we'll go through, actually live with it, particularly the vascular access. This event is supported by our Edward Life Sciences, Bard Incorporation, Terumo Life. These are our faculty involved. Myself, Dr. Kini, Dr. Tang, Dr. Larakas, all same, and Pedro Moreno is the moderator. And today, our cardiac anesthesiologist is Dr. Cesar Rodriguez. So with that note, we are ready to present you. This is a case of 104-year-old plus female with progressive dyspnea and for last few months, and has a non-ischemic cardiomyopathy, has other conditions. And we did was in heart failure back in July, had a balloon aortic valvuloplasty, good medical therapy, and here with a severe calcific aortic stenosis with intermediate degree of CAD, which has been managed medically. So with that note, I'll just hand over to Dr. Stem Larakas to talk about the transthoracic echo, which has a severe AS on the recorded. Now we should show the live. So Stem. Okay, we are not seeing the echo on the screen. Please put the echo on the screen. Yes. Yeah.
Okay, Stam, we're listening to you.
The PA pressure is 50 plus 10, about 60, so the patient has about moderate pulmonary hypertension. These are the pulse wave through the aortic valve. The stroke volume index in this case is 32, is low aortic stenosis. And the gradient, you see the velocity maximum is about 4, peak gradient 65, is 45. Aortic valve calculation is about 0.4, 0.5 centimeters squared. The rear aortic stenosis 45 gradient. low gradient. Stroke volume is about 42. This supports an image to make sure there is no recurrent effusion. Be aware after the case to make sure we don't have anything new happening. This strain, just for the people to know, because sometimes usually the EF can be peculiarly big. So the strain here, global strain was 8 times 3, 84, 24 by the strain, the injection calcium. So about 24 historical percent, as you can see here, septal wall is hypokinetic, as you can show on the strain map as well. Thank you very much.
Okay. Fantastic, Stam. While maybe some questions will come, we can go back to slide presentation, because actually here will be the performance of the vascular access live we wanted to do. And so this basically a CTA, aortic annulus. Gilbert, you want to comment on how things are here?
Yeah, I mean, this 104-year-old clearly has a small aortic root and small annulus. You can see mean diameter is a little bit over 21. Area is on 340, but very horizontal root, 80 degrees, so it's almost vertical in terms of the annular plane. Next slide. And you can see the sinus is also very small. You can see around 25, 26. STJ is also very small, 23. The left main and right coronaries are quite high, so there's not an issue in obstruction. LVOT is also very small, around 21. Next slide. I think Sahil can comment on the access, and we will show you some live angio as well.
Yeah, I think access is very challenging here. There's tortuosity as well as calcium all across the medial and the posterior wall of the vessels. The left is reasonably sized, but there is an area which is calcified, and narrowest is 4.4. So I think this will require balloon angioplasty before we go in with our 14 French sheath.
Okay.
Yeah.
And then this is about sentinel issue.
I think sentinel is not possible. It's very tortuous. I think the risk of trying to navigate that tortuosity, you're trading off stroke because of manipulation of the sentinel in those vessels.
Okay, beautiful. So this is now we decided SAPIEN S3 Ultra, and the size wise based on the what fits in 23.
20 to 23.
20,
It's between
yeah.
two sizes, but this is
Yeah.
a 104-year-old, remember,
Yeah.
and the very calcified annulus, and obviously tissue very fragile, so we don't want to have any risk of annular injury. So because of that, we rather go for nominal 20,
Okay.
And then we'll see how the echo looks afterwards.
So we are going with a 20. I mean, again, it could have been in the border of 2023, but in this particular case, 20 is all right. And just to sum up, this is our Centenarian patient. Who is, the question was, why to do TAVR? Well, this patient, as I mentioned, had a balloon valvuloplasty back in July, and is functional despite the age. And therefore, despite advanced age, a heart team discussion felt it is appropriate for TAVR, and that is what we are going to use a 20mm SAPIEN 3 Ultra with, require some PTA of the femoral artery before advancing our catheters. Okay, now with the Kini and to Sahil, tell us where you are and what you are trying to do to get the good vascular access in this case.
Let's show the engine.
So now we should go back on fluoro, please. And you take us from there now.
So
Go to the fluoro, please.
the main access will be from the left side. They already done the PTA for the left side. So we have a pigtail on the right side. So I think the plan would be that we are going to say, you see the tortuosity. I'm going to display it.
Yeah. No, I don't think so.
Yeah, this is it.
So we just dilated once, already PTA done. Goal would be that we have a pigtail, we'll leave a Lunderquist on the non-access side, and then we'll plan. So this is the Lunderquist that will straighten the vessel. Good.
And just to say that a lot of people do use Lunderquist for the valve deployment. I would say probably in a 34 Evolute might be,
Right.
have some role, but we felt that it's a very aggressive wire and cause some dissection, perforation. So we don't use Lunderquist routinely. Here we are using it on contralateral side to straighten out iliofemoral and distal aorta. And of course, still they've done up some PTA already, but still need to do further.
Which balloon was used for the PTA?
6.0 Armada balloon.
6.0 Armada, yeah.
Yes. Okay. Yeah, the calcified segment is around 4 and 5, so it's very small. So
And you
6.0 is
got good
appropriate.
expansion on the balloon, on the inflation.
Yes.
Now, what about using the IVL? We had done some cases. in this particular case, maybe both Sahil, you can say that why not IVL to give a little extra leverage in terms of fracturing that calcium of the calcific iliofemoral area.
I think, Dr. Sharma, IVL is good if there's a lot of medial calcium.
I see.
This one was not circumferential, it was more patchy and very thin layered. So I think we can avoid IVL in this case.
What's the angulation?
Plus there are cost implications of...
Yeah. Okay, so this is going there now. What sheath it is? Anybody comment?
14 French Edwards.
14 French Edward sheath.
Very nice.
Okay.
When we tried it first time, we had issues. That's why we pre-dilated with the 14 French sheath and then this Edward sheath.
And another issue is that you see the abdominal aorta is completely calcified.
Yep, very calcified.
That is the challenge to navigate the tortuosity as well. And that's putting another stiff bar on the contralateral side helps with the tracking of this particular E-sheath.
So basically use a body wire there to
That's it.
facilitate.
Yep. So many of our techniques of the coronaries are used for to improvise. Come here, scientist. Tie her back.
Now, with this extremely horizontal valve, Dr. Sharma and Dr. Kinney, you expect resistance for the S3 to go through?
Yeah, I think we expect resistance in anything for this particular case.
Exactly.
But the way things are, since the sheath is there, and it is a challenge in all throughout, but our goal is here to show our audience the challenging case, because otherwise TAVR, as we all know, has become a routine. 712 centers in United States, and last year's number may be down than a year before because of COVID, although maybe still high, because only growth which we had even in the COVID era at Mount Sinai was TAVR. 370 versus 318, 370 in 2019 and 382 in last year. So that's the only thing grow. Everything else has a 16 to 18% decline, and the national number we do not know, but we know about 70,000 plus in 2019. So key is that this case is very challenging. Now whether this makes it to the history in terms of the oldest patient in America, I don't know, but we expect to write the case report. We already spoken to our fellow, and as I mentioned that we looked into the literature, and we could find only 102-year-old patient having the TAVR in United States. Published literature. We do have published in 2004 our BAV article where we have patient up to 104, which we did the BAV.
Very nice.
Okay, tell us, Anu, what did you use to cross and what catheter?
AR2 with the straight Terumo wire.
Yeah. Okay, and what is the plan now?
I think we'll exchange it to a pigtail, then change to the TAVR wire. We can show the gradient here.
Yeah, we're okay. Good. Okay, show the gradient, because
You want to take this out?
we can take this Landerquist wire out, right? We do the hemodynamic for the gradient. You want to show that, right?
Yeah, we can do it.
No, we can go back.
Okay.
If necessary, we can put back.
Where's the contrast connector? Oh, we have to switch.
No, we
back.
switch.
Okay.
We have to switch.
AK, what are you saying? Okay.
I guess, Dr. Sharma, what the whole world may ask is, what is the cost, the risk-benefit first, in these cases, Centenarians or non-Centenarians, and second, the cost-benefit of this procedure. What do you think about those?
Well, I mean, the question is the bottom line. To me, biggest thing here is, what is the, we call it a marbles intact. So if a patient has marble intact, which is like brain functioning normally and able to do day-to-day routine, it's not we are talking a patient who is in a nursing home, and so is cared, adult daily living, being cared by some other people, no. So otherwise, it's appropriate or not, yes, it's certainly appropriate. And then again, what we do in these cases, like done in this particular case, do the BAV, see how things are. So maybe before re-stenose, something will happen to these patients if that had to be. But if patients who survive like this, and we have handful of them, so it's now question is, do what again? You saw it, how difficult the vascular access was, and whether we are, again, being done purely for symptom relief, making the day-to-day activity better. So with that note, we show the gradient. Can we show the gradient first? No, we have not shown yet. Can we show the hemodynamics, please? So it's still quite a high gradient. Yeah, okay, now you can do. And we are ready now.
Linderquist.
No.
Yes,
I don't think we need it again, but we can do it.
We may need it.
Okay, get the supercore.
Okay. So now that is one. Now second question is cost benefit. So if we talk about the financial point of view, that are you going to lose money in this particular case for the institutional point of view? And so answer to that is no, because this is approved procedure and with the approved indications. So clearly that we have a clear indications in this particular case of and meeting all the demand, all the gradients, the quality of life and all those factors. So therefore appropriately indicated will be fall into the DRG for the TAVR procedure with comorbid condition.
Absolutely. There is a recent TVT registry publication that about 15% of patients, which is a significant number, will be non-Centenarians.
Yeah.
And even though the in-hospital mortality as well as the one-year mortality, the 30-day and 1 year is absolute 3% higher than the less than non-Centenarians. When you do the risk-adjusted mortality, it's actually the same.
Yeah.
And equally with the stroke and other complications. So you're saving, and you add about 1.6 years of life, which by standards may be worth it. Society has to decide, but it will be between $50,000 and $100,000 per year life saved. Yeah.
Okay. So this
Very
is now
good.
being changed. The AR2 is being changed to the pigtail, and now we are going to use the safari wire.
It's a small LV cavity. That's why we go with the safari wire here rather than the usual confida that we have used in a few other cases.
Now we have no blood pressure measurement except by our anesthesia team. They have the measurement of the blood pressure. Okay. It's on the pump, yeah. Only thing we are just not showing it. Okay, we are ready with the balloon. Okay, what size balloon we are doing? 18? What was done in July?
18.
Okay, 18. Is 18 okay,
So
everybody?
can we get one
Yes.
more
Or we go
down
20?
happen, please? Yeah, and give
18
another
will be enough
250
give.
fluid, please, 250 cc.
Huh? We should go 20, right? 18 is fine because of the 20, the valve. Okay, all right. We are actually same, that we want to be conservative little in this particular case with all valve sizing, balloon valvuloplasty and so, and we are 18 with a syringe attached, right there. Good. And valve should be ready in case severe AI occurs, which occur in a small % of cases. Good.
Yeah. So that feeling, Dr. Kinney, right there, you felt resistance or not much?
No.
Yes.
Huh? You
Yeah,
felt it?
that's the key.
Good. Fine.
It's like,
Yeah, but again, the gradients were there and some fracture of the valve has taken place by our earlier BAV.
yes. Would you daughter again, or you just go ahead
No,
with
just
the
I
valve?
think one shot, as long as you have done one and knowing that, yes, if I'm doing a standalone BAV, I will do a one more dilatation. But since this one, we are all good. So there's a 20 millimeter nominal volume.
Yep. Check orientation, it's checked.
You'll speak for orientation.
Orientation, okay.
Okay,
Looks
the
like-
operator,
Yep,
first
that was
operator
low-mo.
checking the orientation
Orientation
confirmed by
confirmed.
me.
Skirt is ventricular.
Good. Leave it.
Who's holding the wire?
Me, I'm holding. Go. The sheath may still give little resistance. Good. Coming slowly and slowly.
Okay, good. Okay.
Good. Okay, now show what we are doing here. We should be on fluoro and manipulate.
That's the wire.
Yeah. So putting the stent on the balloon or the valve on the balloon. Yeah, valve alignment. Good.
Let's take this supracore out now and put the pigtail set up so we're ready to go.
Yeah, let's cross.
No, there's
now.
no. It won't matter.
I don't think so. I got the. That's
Good. Good.
Keep going. Advance.
Okay, now we are advancing and rotate.
You can see how horizontal the aorta is.
Good. We are in.
Almost 90 degrees. I'm going to the angle now.
Yep.
Advance the
watch
wire.
yourself.
Advance the wire.
Yep.
I'm going to bring the hypotube behind, back.
Valve has come out a little bit, which is okay.
Okay, that's good.
Let's
Okay, you're good.
magnify in
Position
now.
is.
Yeah. Good.
Okay, it's pretty good there.
Let's
Yeah,
do it.
Yeah, it's a lot of AI.
That's
180.
So we always check at the pacemaker that your valve is
Okay,
where
stop.
it should be.
Yeah. Okay.
Good
Yeah,
spot.
good spot.
Everybody agrees? So pull
Yeah,
back
go
the
slow.
pigtail.
It's a little high on the versus the left, so just go slow and self-centered.
Good.
Yeah,
Okay,
flex it.
180.
Yeah.
What do you want now?
No, that's good. Okay, just
Okay.
want to check.
Good. Okay, we are going up now. And we tell our anesthesia colleague that we are going up. So just loud so everybody is on the same page.
Okay, yeah, now it's
Yeah,
capturing.
good. Capturing nicely.
Okay, I fully inflated at 6.
Good.
Stop
Okay.
pacing. These are
Okay.
resuscitate.
Good.
Okay.
So keep it there in case we have to add some
Yep.
extra fluid.
That's
Huh?
it.
No need.
Let's take an
No, but
aortogram.
we'll see. I'm saying that
Yeah.
we have the capacity here. If need to be, 1 or 2 cc's can be added on.
1 cc.
We are on the
Okay, let's-
minus
It's okay. No.
side. Yeah. Okay.
Yeah.
Pressure is back. Hemodynamics you are seeing. We are ready for the aortogram. Good. Got a pigtail. We'll do a hemodynamics
Inject.
if necessary. Yeah.
I think a central AI.
Central.
Is it? So
Yeah.
I want to
Yeah.
confirm with the echo.
Okay, yeah. Malcolm and Stam.
Look at the pressures.
That's good.
So we are actually just upgrading the mic for Dr. Larakas.
Yeah, thank you.
So everybody can hear well.
Sorry? Yeah, okay. The position is good of the valve.
Okay, show the echo please on the screen now.
Yeah.
Live echo.
We have
You can take away the hemodynamic. Good. Yeah, now.
appears that
Okay,
there is
fine.
central AI. Okay, let's go back. Let's go down. Apical views.
It's only central, right?
Yes, central. It looks valvular, yeah.
Let's come out. Sorry, not yet. Not yet.
The function is good. Okay.
Did the LV improve a little bit? I know LV has been on 25-30%.
Little bit. Yeah, minimal paravalvular, minimal PVL.
Good.
Show us the short axis.
Short axis was a little bit tough,
Oh, okay.
so that's why we went straight to
It's okay.
the apical views. But you can see nicely the views, this 3-chamber view. Yeah, no much AI,
Okay.
minimal PVL, and some central aortic.
Good. Okay, so we are going to do hemodynamics and then we take the Hands out, and then we are going to take the wire out and then reconfirm the.
And no effusion, no pericardial effusion.
Yeah. Yeah, diastolic pressure is pretty good, huh?
Pretty good, yes. Good.
The patient requires some sort of epinephrine, or is this her normal pressure?
Caesar, did you give any major pressure push earlier or nothing now, right? No. Okay. We have to flush the femoral as well as. Good. Okay. Let's see the hemodynamics.
Beautiful.
No gradient. And diastolic about 80. Beautiful.
Yeah,
Fluoro, we can pull back. And then we are going to do fluoro. Okay. Now we do aortogram now again without the, because it was central earlier. Yeah. Good. Ready? Yeah, here. No? Okay, echo team, please.
Yes.
Repeat. Go to live echo. So it looks like 1+ here, but there is very high blood pressure right now of about 180.
Yeah.
We just need to concentrate on that central AI now.
Yeah, it's not much, you know.
Good.
It's minimal PVL, at most mild valvular, at most.
Okay. I would say the mild is a winner in this case, considering all the facts. And you saw that how we were able to implant in this horizontal aorta our SAPIEN 3 Ultra valve, 20mm.
Not much. As you
Right.
can see, minimal
Minimal.
PVL and yeah.
Okay. So now the whole question will be, Sahil, tell us what will be your access, what you are going to do from the access point of view. Do you have a contralateral wiring here, or what will be the goal now?
Can you lower the pressure, please? We're
Okay.
closing.
There is a plan for bailout stenting, which we had already decided. If we had discussed with the patient's family that if need be, we'll do bailout stenting. I don't think we need to. We have got a good stick, so with just balloon angioplasty, we should be okay.
Okay. So what we will do is we go back to now, Pedro. Any other questions from your side or anyone? Then we go to our presentation while we'll do a live closure with all the fellows and with the Sahil and our team.
Yeah, I think we're good. There's no questions from the website, so I think it's an amazing case. Go ahead, Dr. Sharma.
Okay. Anu, you want to comment on this patient? It's your patient with that age, because the question always comes that do you do procedure in this elderly patient, and so.
No, as long as the patient is, agreeable, as well as the family is agreeable, they understand the risk at this age. Patient, we knew, like you mentioned, is ambulatory and able to do things, wants to, have a quality of life. We should operate to every patient, irrespective of their age.
Okay. Perfect. So what we do now, put Dr. Khera on the one side and go to the slides on the right side, and we go to our presentation. Okay. So good. So now, so this, what I did is that every time we just present one point. So this I today felt that latest issues in transcatheter structural heart interventions, that some few registry data have come, because all the randomized trials we already spoken. One is the TORCH BAV data, partner to SAPIEN 3 diastolic dysfunction data, and re-access coronary. So starting with a bicuspid aortic valve, which not for this case, but we know the bicuspid is an issue. Eccentric opening, calcific, concomitant aortopathy. So all these really makes bicuspid is a kind of not ideal for TAVR, but we did the systematically studies of the registry in the high risk, intermediate risk, and low risk, and after appropriate discussion with the heart team, cases which are appropriate for bicuspid aortic valve got the both SAPIEN as well as the evolute valve, and both are approved for this purpose now. And we know that, so question always comes, the various morphology of the bicuspid. All bicuspid valves are not same. RFA, no RFA, and RFA calcium, and the leaflet calcium has a prognostic importance. This paper in really showed that once you have calcification of the RFA and the leaflet is associated with bad outcome, very high mortality compared to absence of it. So each bicuspid aortic valve has its own morphologic features, make it suitable or unsuitable for TAVR procedure. We also know that in these cases, there is a higher paravalvular leak, there is higher neurologic event, and this actually the earlier data from Raj Makkar's team on the registry, that 30-day and 1 year. You see that while other outcomes were similar, even mortality, but there is definitely a signal of higher stroke rate in a BAV patient compared to TAV patient. So bicuspid versus tricuspid, higher stroke rate. And that actually went to this the recent paper of the brain injury after transcatheter replacement for the bicuspid valve from China. And basically they took the patients systematically, did the diffusion MRI. The bicuspid versus tricuspid, and they found basically that yes, the overall lesions which occurred goes to all the areas of the brain, but more so in the bicuspid, that lesions are more and they are larger. So that is the key. More, higher number as well as the larger number of lesions with the bicuspid valve versus tricuspid valve. And so therefore it showed that yes, brain injury is a very important issue, so we should try to do everything possible in these cases. Particularly the question is why this happens, and I have put the factors. One, there is because there is not a clear-cut tight fit, so higher PVL, higher pre and post balloon dilatation, then of course prolonged procedure and longer rapid pacing, many times to fit the valve, higher AV calcification, all these contribute to a higher brain injury in bicuspid valve. So therefore, if not, unless really contraindicated, all these patients should get the Sentinel approved device for preventing this brain injury. Then second study came is about the diastolic function and its predictor. And this is the data from the partner 2 where SAPIEN was used, and SAPIEN intermediate risk registry, and basically showed these are the various grading of the diastolic dysfunction based on the E to A ratio, diastolic dysfunction 1, 2, and 3 being very significant, which occur. So diastolic dysfunction more than mild occurs almost in 40-50% of patients, and what has shown that once you do the TAVR, your diastolic dysfunction improves. So grade 2 and 3, as you can see, many of them become grade 1. So TAVR is the answer for diastolic dysfunction also. You say, well, how does it matter? Well, it matters because of the diastolic dysfunction is predictor of your mortality and rehospitalization at a 1 year outcome. So therefore, if you can see here, all-cause mortality and rehospitalization is significantly higher patients who have diastolic dysfunction compared to who did not. And this actually have put it together that clearly that improvement of the diastolic dysfunction occurs in many patients, and subsequently once your diastolic dysfunction gets better, it is associated with also lower mortality. So key is one, diastolic dysfunction pre-TAVR, higher mortality. Second, after TAVR your diastolic dysfunction improves. So your diastolic function, I would say, improves, associated with the lower mortality at 2 year follow-up. So that's what we learned from the partner 2 SAPIEN 3 registry. Now the coronary access has been a major issue. This is our paper a few years ago in JAC, that how difficult it is, particularly with the evolute valve, to engage the coronary. We have the algorithm of various coronary catheters, what you should use, and you can see majority of the SAPIEN cases are okay because the coronary height is above the valve frame, and this actually has been looked into the coronary re-access study done from Italy, various centers, and what they did is, so take about 300 consecutive patients and did a pre-cath and then did the cath after TAVR. So about of the 323, 7.7% had unsuccessful coronary cannulation, and of the 23, 22 were the evolute. So very high incidence of unsuccessful coronary cannulation, selective coronary cannulation after the evolute valve. So now they went through the various factors that what happens, whether time to cannulation, contrast media, right coronary, left main, all those are more complex. The coronary, particularly left main, and is more difficult after the valve, TAVR valve implantation, and of course time to cannulation become increased post-procedure. And this is true for both right as well as the left, and they suggested various catheter algorithms. What they learned also is a transcatheter aortic valve, sinus of Valsalva relationship. That was the odd ratio. Then transcatheter aortic valve type, and then of course the question is implant depth. So evolute and implant depth. Lower the one, is it trouble? So implant, particularly the commissural alignment, which has been propagated, really understood by our Gilbert Tang, the surgical director of the transcatheter program at Sinai, and has really, I would say, the spokesperson of the commissural alignment to have less trouble at follow-up. So I'll ask Gilbert to speak in few sentences. Tell us a little more about the commissural alignment and how can we circumvent this problem, particularly with more and more cases we are doing a young people, the TAVR, knowing that they are going to get a coronary disease in the future.
Well, I think the background of this idea is that with surgical valve, there's always a line. So no interventionist ever had problem with cannulating coronary after surgical valve replacement. The transcatheter valve has a stent frame, so that's an issue. And in certain cases, if you have a stent frame and a commissure facing a coronary, it just creates a higher physical barrier to access. So we've looked at this. Our paper has been published in the JACC intervention, looking at SAPIEN 3 and Evolute and even accurate valve on this topic.
And therefore, how do you make it that it should fit into the commissural alignment?
With the SAPIEN 3 valve is a shorter frame, so it's less of an issue, but then there's no really consistent way to do it, as that's what we found over 400 patients. But with the Evolute, if you put the flush port facing away from you when you insert to the femoral artery, it does improve the commissural alignment and may make the coronary access easier because at least you don't have a commissure in the way. Now, there is still a stent frame in the way that you have to get around it, but at least there are more diamonds to choose from to access the coronary.
Anu, you want to comment on this coronary access, knowing that recently you have done few PCIs through our Evolute frame?
Yeah, you should have shown the animation that we just created and released the second version of our TAVR cathode. In the animation, I clearly show what is commissural alignment, and if depending on where the commissure is, how do you rotate your guide or a diagnostic catheter so we can go through the right diamond to get into the left sinus. I think the central figure of our paper exactly tells everything. What are the 4 factors that are necessary? If you see there, one is the sinotubular junction, the sinus height, leaflet length also matters a lot, the width of the sinus of Valsalva, because you could have whatever orientation, but if your Valsalva is large, easy to cannulate. But what we want to say is the depth of the valve, which is probably the key factor, and then the commissural alignment. That because the skirt and where the commissure is a key factor for us to reaccess the left main.
You want to just ask Andrew to bring your latest the
animation.
Animation, yeah, latest animation. If they can bring it, we can show it towards the end. We have a few more minutes on this point. So key is, it's a big issue. A big issue. I mean, I can tell you that it's a proprietary. I have suggested them one different way on this point. That what can we do for the coronaries, but this will become continues to be a big issue to access the coronaries, and particularly one of the thing happened that after the approval of the low risk TAVR, the used to be like 65-35, 65 SAPIEN, 35 Evolute. Now actually it's almost 70-30, because clearly people are concerned about the coronary access, if particularly young person and who has CAD, right? I mean,
I think the issue is not so much you, Dr. Sharma, who's a TAVR expert, but it's the people who are out there in the community who don't do TAVR, and then in the middle of the night have to deal with this situation with a TAVR valve to try to reaccess coronary. I think that's probably the tough part, and that's why Dr. Kinney developed the app, so everyone, wherever the world, they're dealing with the situation, can learn how to access the coronary just on their phone.
Yeah, and I can tell you, just 2 months ago, I had a case I had done the PCI on that patient 5 years ago. Then patient has a valve deployment tower, evolute outside. They didn't think about commissural alignment, and patient came with a non-STEMI. And the right coronary they could not engage. And I can tell you, even for me, it took half hour to engage the right coronary. Very difficult. Although we did a rotationectomy and needed IVBT because but just to say, the coronary re-access will become a new field. Just like when we put a DES, we said good, restenosis is cured. Then we got a new disease, just the ISR, instant restenosis. So clearly, we have created a new issue about the re-access study, and majority of the studies have shown that evolute continues to will give a trouble. Hopefully, this alignment and with the depth will help to mitigate that factor. But particularly for the SAPIEN point of view, that is fine as long as it doesn't obstruct. Now, as you just want to say also, if you go with the data, acute coronary obstruction is slightly higher in the SAPIEN studies compared to evolute. We are talking about like 0.4 versus 0.1. But that's a very, very small, because cases which are low height, we are not doing the SAPIEN valve because there's no reason, because there are other options if they're available. Many of those patients with a low height are actually a patient with an intermediate risk who wanted TAVR, but we send them for surgery. Because height was the RCN left main was 7-8 millimeter. So we said go for surgery. So key is this re-access issue, and coming with the new programs and apps and animations and alignment and maybe some new stent design within the evolute might help us for future re-access. So let's say the three take-home messages. One is that TAVR in patients with balloon with the bicuspid aortic valve is associated with higher CVA and the new cerebral lesions. With these results in mind and higher mortality in some BAV morphology, concern should be exerted in recommending TAVR in low STS risk BAV patients. Right? You agree with the...
Yeah, I think we don't know the durability in these morphology, as you mentioned. So I think if they're low risk, young patients particular, so much low risk, if they're low risk 80-year-old and then anatomy is favorable, I think it's reasonable. But if like a 65 or even 70-year-old, if they have hostile anatomy, as you show in the Raj Makar's paper, they should be strongly considered for surgical option first.
Okay. Anu, you want to comment on this point of the BAV issue for bicuspid aortic valve and TAVR? I know you gave yesterday the grand round about with the multidisciplinary approach in selection of the TAVR in these complex group of patients.
Definitely, I think BAV as well as this patient, we were a little concerned about BAV recrossing. Again, we want to get a gradient post BAV. The multiple catheter exchange we should try to avoid, especially if we are not able to place a sentinel in the patient.
Yeah.
So bicuspid, I think you can always say that, they have calcium as well as thick raphe. So you have to be careful that risk of CV are definitely higher since the calcium spicule can fly up to the brain.
Okay. Second, the diastolic dysfunction is an important determinant of outcome after TAVR. So systolic everybody knows, right? Systolic dysfunction correlate with long-term outcome. But diastolic dysfunction also, and studies have shown, patients with improvement in the severe diastolic dysfunction post-TAVR have improved outcome of mortality and rehospitalization. The biggest issue with the diastolic dysfunction is increased rehospitalization with some increased mortality in the advanced diastolic dysfunction, and that's get better in about 30% of TAVR patients, and they have subsequently improved lower mortality and lower rehospitalization. The last point, the coronary re-access after TAVR, especially after evolute, remains problematic. Commissural alignment, as we have spoken, at the time of evolute valve deployment has shown to minimize re-access issue, and hopefully that everybody will pay attention to that paper and try to do when the valve is being deployed. So let's do the three questions while we are getting ready for TAVR cath animation. The following are the usual higher event rates after bicuspid aortic valve versus tricuspid, stroke, higher mortality, new cerebral lesions, and PVL. Remember the studies, there are no randomized trial, but comparative trial, there is no difference in mortality. It is only in the stroke, new cerebral lesions, and PVL. Then following the true statement regarding diastolic dysfunction in TAVR patients accept Moderate to severe diastolic dysfunction is common. Diastolic dysfunction is associated with higher mortality. Diastolic dysfunction does not change after TAVR, and diastolic dysfunction improvement post-TAVR is associated with lower mortality. Clearly, we know that some percent of patients, about 1/3, will get better after the TAVR diastolic dysfunction, and it correlates with lower mortality and lower repeat hospitalization. The last question, number 3, following are the findings of the re-access study of coronary engagement post-TAVR, except the highest failure rate in evolute valve, higher failure rates in left main versus RCA, higher procedural time and contrast use post versus pre-TAVR, and higher implant depth is associated with higher failure rate. So clearly, whether you do the left main or RCA, both are difficult and so. So answer that should be failure rate in the left main is much higher than RCA, and implant depth is associated with a higher failure rate of the re-access. With that note, we are ready to show our animation.
It's going to take time to change the slides. Let us show what Sahil has done.
Yeah, show now. Meanwhile, our vascular access
picture.
issue.
No,
take us
nothing.
through. You show any other picture there or no? This is it?
This is it.
Okay. Now show the fluoro, please. Yeah. You want to just show what you're seeing it? This is now the sheath has been out, and vascular, you can see there. What is the other? Is the vein?
That's the vein.
Vein left, and this was the main axis, and you can see here has been completely taken care of with no dent, and of course you do an angiogram. So did you do a balloon
angioplasty? Yeah.
No, this
and the dry
started
closure.
here.
So tell us exactly what you did, because we're taking apparently 1 minute to get the video, and we have few minutes on this. So what did you do basically here?
So initially you go up and over with the V18 wire before you get the main axis. We used a 6O balloon again, and just did a 3-minute balloon inflation at 4 to 6 atmospheres. Usually 0.8 to 1-to-1 sizing with your vessel, and usually gives excellent results. But you see this vessel is extremely calcified. It's all medial calcium. There was a small dissection plane below our stick site, so you have to be very careful. You don't want to aggressively size these vessels. So 0.8 to 1-to-1 sizing with your balloon, and over a V18 wire usually does the trick. So this was our final result, and not a drop of RBC is going out.
Beautiful. Now, on the right side, what are you planning to do on the right side now?
We will manual it.
Okay.
They're very calcified.
We're very calcified.
Yeah.
Okay. And so what are the 2 sticks on the right side?
So one is for the pacemaker, and the other one is for the non-main axis.
Okay.
And this EF was very low, a patient was very old, so we got 2 vein accesses. One we gave to anesthesia, and one was our backup for bypass. So.
Okay. Are we ready for that? Yeah. So we are ready for the cath, the TAVR cath animation. So from procedural point of view, yeah.
Okay, this is the second version of the TAVR cathode actually, which has we upgraded it to a website now. So the new features that we added for TAVR cathode, initially the first version was only a app, but this time we have created a website. What we also did was added case reviews. All the cases that we have done post TAVR, how to access, those cases have been placed on the website. We have shown the case, what are the various devices we used and how we did this case. Most important thing, everybody always asks us is there an offline functionality? So usually what happens, majority of these apps, when you go to a place where there's no internet access, sometimes the cath lab are in the basement or cannot get internet access, that app does not work. So there's an offline functionality, and you can see a beautiful upgraded interface and a strong search function. So any part of the app you're able to search now depending on what you want to do here. So the one important and beautiful thing is the animation that we have placed, and you are able to access the animation immediately, not having to go through multiple steps to see exactly where these animations are. So you see examples of the animation of the TAVR cathode. We are showing how to access, and what we want to show is this kind of a bird's eye animation where you're seeing from the top. So this is what I was talking about. This is the evolute valve. And when I am talking about bird's eye, see what you can see here. So you are unable to, wire it. So you have to rotate the catheter exactly either counter or clock to get into the right diamond. And once you are at the right diamond, you will take a coronary wire and then advance the coronary wire way further down. Also, we always say it's best you have a guide liner. Many times the guide does not go forward, but the guide liner or any guide extension catheter works. So you see here the guide extension catheter is in the left vein, and you can do either you want to do an angiogram or you want to perform the PCI. You can do it the way we have shown in this animation. Once everything is done, you just have to be very cautious that how you come out. You see here, you come out carefully. Everything gently comes out, the wire comes out and come out with the guide. This is a animation.
Beautiful animation. All right, Pedro.
Yeah, this is wonderful. I think we have seen today a very, very illustrative case of a centennial patient successfully done. And so thank you so much for the heart team members of the Cath Lab, and thank you for joining us for this exciting case. The recording of this case will be archived on our www.cclifecases.org later today. Remember, our structural life cases are transmitted the second Tuesday of every month, and it's actually every 2 months. So today is January, the next one will be in March, the second Tuesday of the month at 9 a.m. Thank you so much for joining us today.